Good morning, everyone. In today's session, we'll be talking about the importance of the radiographs and how we can interpret it to derive any diagnostic information, and how we go about the treatment plan for that specific complaint and as well as other complaints also. In the previous sessions, we have talked about what kind of radiographs are available for the dental physician. For what kind of complaint do we have to prescribe the specific kind of radiographs, and the different types of radiographs which are available to the dental physician. Now, it's not only it's imperative not only to take the radiographs for the specific complaint, but also it's important for us to interpret that particular radiograph so as to derive as much as information about the chief complaint of the patient and how effectively can we treat it. So today we'll be talking about the various principles of this radiographic interpretation, be it any kind of radiograph. We'll be talking about radiographs in general. So what are the main objectives of taking a radiograph or deriving any information from the radiograph? The first and the foremost objective is to identify any particular disease. Now, to identify any particular disease, you need to know what is normal and abnormal in a specific radiographic image. To that extent, we have to know the specific geographic location and specific typical features of any particular disease which we might be looking for. Now, this information is derived from the provisional diagnosis of the chief complaint, which is derived from the history and the intraoral or the extraoral examination. Now, after the person arrives at a provisional diagnosis, then this radiograph helps in confirming or negating the provisional diagnosis as such. So, it is very important to notice the presence or the absence of the disease, which is the first objective of any radiograph which we take in a dental clinic. Now, the next objective is the information from this disease. Now we have identified a particular disease which is located in specific region of the radiograph. Now the next important thing is to know how far and how extended is this particular disease. So need to know the nature, whether it is benign or malignant, or it is any other kind of what the basic nature, the characteristics of the disease is to be known. And next important thing is to know the extent of that particular disease. Now, the extent gives out various informations regarding the chronicity or the aggressive nature of the particular disease. So, the extent of the disease is far more important. So, we have to clearly delineate our area which is affected by that disease and which is normal. Now, the next or the final objective is to arrive at a differential diagnosis which enables us to propagate or propose to the patient a specific treatment plan, or it is helpful for the dental physician himself to either go or not to go for further investigations to confirm that particular disease. So to derive at a specific 1, 2, 3 differential diagnosis, interpretation of the radiograph, which is the primary or the chairside investigative method, is of primary importance. So what are the requirements for interpreting a particular radiograph? Obviously, a radiograph which has a different scales, the gray scale, different shades of dark, it has to have an optimum viewing conditions. Now, what are those optimum viewing conditions? You need to have a specific lighting conditions. The ambient light should be sufficient enough so that we can make out the minor changes in the contrast, which is evident on the radiographic image, as well as sufficient brightness. The ambient light and the sufficient brightness from the viewing box should be necessary to make out minor changes to differentiate the disease from the artifacts. So this lighting conditions, a specific magnifying glass if you have to look in for a very minute details within the radiograph, all these optimum viewing conditions are of primary importance while dealing with a radiograph. Now, also, as I said, to understand and to differentiate the different grayscales, the grayscales which is normal or inherent to the radiograph and which is specific to a specific kind of disease. Now, to differentiate these different shades of gray, it's of primary importance which we that we know that what are the different shades of gray or what are the different kinds of contrast which are available or which can be seen on a normal radiograph. Hence, we can differentiate it from the abnormal grayscales. Next is the critical assessment of the radiographic quality. Obviously, if the developing or the processing of the radiographs are up to the mark, we have a specific quality of the radiograph, which will enable us to differentiate the normal and the abnormal. Also enables us to see the whole extent of the disease or the disease locality also the periphery on the shape, which we can see from the, if the radiographic quality can, if the radiograph can interpret the whole radiograph as such with the abnormality as well as the normal structures surrounding it. So the critical assessment of the radiographic quality is of utmost importance. And then we come over to the knowledge of the radiographic appearances of the normal structures. Obviously, if you have to differentiate an abnormal structure, first we have to know what is normal or the normal appearance of the normal anatomical landmarks. Both the radio opaque structures as well as the radiolucent structures have to be known by heart before interpreting a radiograph. Hence, of course, along with the normal structures, we have to know the radiographic appearances or the typical features of abnormal appearances of the diseases, which is of utmost importance once again. Again, access to previous films, again, just to know the extent or the progression of that particular disease, whether it is increasing, whether it is stable in size, or whether it is resolving. This we can get to know by comparing this particular on-the-spot radiographs with previous films. Then the last one would be the systemic analysis of the entire radiograph. That is basically to propose a specific treatment plan or to know the specific kind of disease, to come to a final diagnosis using these radiographs, which are the chairside investigative methods. So, in the analysis of the intraosseous lesions, which are of which is the primary indication of taking a radiograph, there are basically two basic approaches. The first approach is picture matching or Ant-Mini method. Now, what is this picture matching? This is basically comparison of the radiograph with a textbook image of that specific disease. Now, the basic problem behind this comparison method is not all the diseases do have all the typical features which are described in the textbook, or the textbook images which have a typical feature inclusive of all typical features of that particular disease. Now, this might not be the case in all the cases of which the dental physician comes across in a specific radiograph. Few of the typical features might not be present at that specific stage. It could be present in the future, or it could have resolved at that particular point of time. So comparison or a comparison of this particular radiographic image to that of a textbook image is not always accurate. So there might be some kind of a subjective bias in dealing or coming to a conclusion as to what kind of disease it is. So this is a primary method which gives a general idea or a hazy idea about the disease structure. But the next or the second basic approach gives a more detailed vision or a detailed clear picture of that particular radiographic abnormality or a disease, which is a step-by-step analysis of all the radiographic features of that particular abnormality. Now, what is a step-by-step analysis? Now, this step-by-step analysis involves various steps. It starts with localizing this abnormality. For that, you need to know what is normal, what is abnormal, what are the normal radiopaque structures, what are the normal radiolucent structures, and what could be the abnormality which is seen on a radiograph. So for that to happen, you need to localize that particular abnormality. You need to have a thorough knowledge about the normal and abnormal structures in that specific area. So after we localize the abnormality, we then start to step-by-step analyze the specific abnormality from the inside out. Now that means it starts with the internal structures, assessing the periphery and the shape. The periphery of the abnormality, we need to delineate this particular abnormality from the normal surrounding structures. The shape, which gives a certain amount of clue as to the nature of the disease, or even the final diagnosis of the abnormality itself. Now then we analyze the internal structures, and then coming to the surrounding areas, that is its effect, or this abnormality's effect on the surrounding structures, which means to say the surrounding structures over here is the cortical plate, the periostal reactions, the surrounding bone, the cancellous bone, the teeth, or the pedial spaces, the lamina dura. These are the surrounding structures which we can see, or the hard structures which we can see on a radiograph. The effect of this particular abnormality on the surrounding structures again gives us a clue as to the nature of this particular disease, how benign it is, how aggressive it is, or how well or not well the body is able to cope up with this kind of abnormality, whether it is able to wall out this particular effect which is resulting from the abnormality, or is it failing in containing this kind of disease. So these step-by-step analysis gives a clear picture as to the nature of that particular disease. The location again gives us some amount of clue as to the final diagnosis itself, which is the radiographic diagnosis. So the radiological findings should involve all these different points, according to which we can arrive at a specific radiographic diagnosis, which in combination with your provisional diagnosis, which we can derive at a final diagnosis. So what are these? As I said, the location and the extent, very important, because few diseases or few abnormalities have a tendency to affect only a specific part of the body of the ramus of the mandible or the maxilla. For example, if you take an ameloblastoma, this has a specific propensity to affect only the ramus and the posterior body of the mandible, and hardly we see in the anterior region. So if you see a large lesion with a bony expansion, or the bony cortical expansion with a no periosteal reaction, a large radiolucent space or an area in the ramus of the mandible, we can come to a 50% diagnosis or a radiographic diagnosis of an ameloblastoma, especially if there is a missing tooth or a tooth associated with this kind of odontogenic or a bony lesion. So the next radiological finding is the osteolytic versus osteoblastic reactions. As you know, osteolytic is lysis of the surrounding bone, dissolving or destroying of the destruction of the surrounding bone. Osteoblastic is laying down of a new bone, which could be normal or could be abnormal kind of bone. So this again gives us a clue as to the nature of that particular disease again. Then the characteristics of the lesional tissue, whether it is radio-opaque, radiolucent, or it is a mixed kind of lesional tissue, the internal margins, the surrounding periphery and the shape, all these specific details about the specific abnormality gives us as to the idea, gives us a certain clues as to what kind of disease it could be. Then it's supporting structures of the teeth, its effect on the surrounding areas, the relationship to the teeth, as I said, the periodontal ligament space, the lamina dura, the surrounding bone, the cortical region, the cortical expansions, or the periosteal reactions. All these specific characteristics gives us a clue as to what kind of disease it could be. So the characteristics of the lesion, I'll be speaking about the general characteristics, a few typical characteristics which are normally seen on a radiograph, the bony lesions. The first and the most common one is a geographic pattern, which is limited or specific to that particular region only. As you can see over here, if it is this particular lesion is a specific to the body of the mandible, it could be a unilocular ameloblastoma, as I said earlier, which has a great propensity, around about 70 or 75% of times. Your ameloblastoma does occur on the posterior body or the ramus of the mandible. It could be a benign condition such as an aneurysmal bone cyst or a traumatic bone cyst, or it could be an early stage of a calcified tumor. Or such as an ossifying fibroma. All these have a specific propensity to that specific region, in this case being the body of the mandible. We have another pattern called the moth-eaten pattern. The name itself suggests that it is a group of radiolucent areas, such as a moth-eaten appearance, which with a normal bone in between and specific diffuse radiolucent areas in a specific locality. As you can see over here, it is the specific radiolucent areas with diffuse borders in one specific area. In between, you can see the normal bone. This is chronic, most commonly seen in many inflammatory conditions of the bone, such as your chronic osteomyelitis, which the typical feature being a moth-eaten appearance, or we also have osteoradionecrosis, which also the typical feature being your moth-eaten appearance. Then we have the permeative pattern. Permeative means allowance of this particular disease to spread into the normal bone. The abnormal areas permeates or goes in between the normal structures, so it has a diffuse borders. It is more commonly seen in aggressive kind of diseases, so as to say that the body is not able to wall out this particular abnormality to a specific area. It is not able to cope up, or it is not able to contain this kind of abnormality. The aggressive nature of the disease itself, the destruction of the which is caused by this particular disease, is far more greater than the healing process which takes place into the body's immunity power. So we can see this, the permeative nature. It is quite well spread out. It has diffuse borders, predominantly classically seen in destructive malignant diseases. We have something called as multilocular, which have multiple locules pattern, among which we have something called as honeycomb pattern. Similar to a honeycomb, it has got numerous small radiolucent areas or areas of destruction, very closely packed, surrounded by a normal bone. We see this classically in the early ameloblastoma, as you can see over here, the diagram showing you. And we have something called a soap bubble pattern, which is similar to honeycomb pattern. The only difference being the radiolucent areas are quite larger than what is seen in a honeycomb pattern, and they are fewer in number. As you can see, larger radiolucent areas but fewer in number. This is also seen in ameloblastoma, but in a later stage, when the it basically is arrived or derived from an honeycomb appearance, wherein the small locules, few of them coalesce together to form a larger locule, which so fewer in number. This is also seen in late ameloblastoma. Next, we have something called as tennis racket pattern, wherein we have the septae which are at right angles to each other, giving appearance of a tennis racket-like appearance, wherein all the strings are at right angles to each other. The same pattern is seen in a disease called as odontogenic myxoma. Again, seen in the posterior region, we can see the septae at right angles to each other. We have the scalloped pattern, which, as you can see in the schematic diagram, it is a scalloping nature, just like the scalloping which is seen in the marginal gingiva. The same scalloping pattern or the wavy pattern is seen in a few diseases called as odontogenic keratosis, also called as OKC, also seen in CGCG, central giant cell granuloma, wherein this is one of the typical features when it affects the bony parts. Next, coming over to the internal margins, which is one of the most important characteristics which we have to look into when we are interpreting a radiograph. What it gives us an idea of? It gives us an idea of the growth potential of the disease, as I said, how well it is able to overcome the healing power of the body, and it is able to spread out to the surrounding areas. It gives an estimation. Also, benign or malignant nature, as I said, the benign diseases are most commonly well contained, well defined, thin surrounding or internal margin is seen, but compared to a malignant disease, the body is not able to clearly define or clearly localize or clearly contain this particular abnormality, so it is much more spread out. It has a wider zone of transition. This wider zone of transition is nothing but a transition from the abnormal areas to the normal areas. In a benign region, since the body is able to well contain it, there's a thin level of transition from the abnormal and delineating the abnormal and the abnormal structures. But in a malignant disease or an aggressive disease, we have a wider zone of transition because the body is not so well able to contain that particular abnormality. In the narrow zone of transition, we have four basic variants. The first one is a thick condensed sclerotic margin. And the name itself suggests it has a thick internal margin which is condensed because it is most commonly benign. Sclerotic margin predominantly seen in benign tumors and cysts, as I said already. The next variant is a thick diffuse sclerotic type, slightly more commonly seen in inflammatory conditions. As you can see, it is a similar kind. It is a thick, much more diffuse because of the inflammatory condition, but a sclerotic, well-contained type. So this is seen in an inflammatory lesion. The third variant is a thin condensed sclerotic type, most commonly seen in specific conditions such as odontogenic myxoma, which is, as the name suggests, it is a thin but well contained condensed sclerotic margins. Then we have a punched out lesion, which is more characteristic or typical of multiple myeloma, wherein it has well-defined punched out lesions within the bone, clear-cut radiolucent areas, very much typical or confirmatory for multiple myeloma. Next, we have a wide zone of transition, among which predominantly seen in benign aggressive lesions. It's not always necessary that it is associated with malignant diseases, but also benign lesions, which are more aggressive in nature, where the body is not able to contain it. There also we can see, such as you can see, eosinophilic granuloma or a central giant cell granuloma or traumatic bone cyst. All these are benign lesions but very much aggressive. So in these cases, we have a wide zone of transition, and of course, we have also malignancies primarily arising from the bone itself, or it could be a metastatic disease, wherein we have a wide zone of transition. The supporting structures of the teeth, the predominantly what we look for is a PDL space, which is the first and the foremost surrounding structure which we see. The loss of PDL space is a predominant associated with ankylosis. There is also generalized increase in the width of the PDL space. The conditions are listed over. The periodontitis, where the generalized periodontitis, we have widening of the PDL space primarily because of the accumulation of the inflammatory exudate from the infectious bacteria within the PDL spaces. We have bruxism, which is constant teeth clenching or tooth clenching, which basically strengthens or there's hypertrophy of the PDL fibers, thereby occupying more amount of space. So there's generalized increase in the width of the PDL space. Also, similarly, we have what happens in the orthodontic movement, continuous forces for owing to the fact that we have to move the teeth during an orthodontic treatment. There is continuous forces upon the PDL spaces. There also we have a generalized increase in the width of PDL spaces, and also an inflammatory condition like sclerodermas. We have this generalized increase in PDL spaces. Now we have something called as floating tooth appearance. That is to say, your PDL space is totally lost. The lamina dura is totally lost, primarily because of the inflammatory condition which is associated with the tooth. So the tooth is just rarely, hardly supported by the surrounding bone or the PDL space or the lamina dura. So it gives an appearance on the radiograph that there is no bony support or a hard tissue support to the tooth. It's as if it's floating in the air. It's being held together loosely by the soft tissues itself, which we cannot make out on the radiograph. As you can see, in conditions like periodontitis, eosinophilic granuloma, which I told it is a benign condition but a very aggressive condition, which involves starts from the interdental bone area, extends downward. And we also obviously we have a metastatic malignant diseases like gingival carcinoma, wherein there is rapid destruction of the interdental bone as well as and it goes down below. So it gives an appearance of a floating tooth on a radiograph. So basically what we see in the relationship of the teeth is how the teeth have responded to the growth of this particular disease, whether it has moved away from the disease or it has or whether the disease is so aggressive that it hasn't given chance for the tooth to move away, but it has directly resorbed that tooth root itself. So the various kinds of resorption, the external resorption which takes place owing to the aggressive nature of the diseases, gives a typical pattern or typical way in which it is being resolved. The first one is a knife edge pattern, which is typical or almost conclusive radiographic conclusion to ameloblastoma, as you can see in this radiographic pattern. Then we have a multiplanar or multi-root planes, where there is a parallel destruction or the external resorption of multiple teeth, hence the name, which is again typical to central giant cell granuloma. As you can see over here, there are multiple teeth which are parallelly leveled out because of external resorption. Then we have spike pattern, wherein the resorption takes place from either side, from the mesial as well as the distal part. So it gives a spiked appearance to this to the tooth roots which are involved. Again, this is typical of chondrosarcoma or osteosarcoma and multiple myeloma. As you can see over here, there is sharp spiked appearance, again owing to this aggressive nature of the disease. Then at last we come over to the periosteal reactions. Now the periosteum being the outermost area, this is one of the last structures or the final structures which are involved before the disease outposts from the bony structures and enters into the soft tissue. This is a final frontier for any particular disease to show its effect on the radiographic structures. In this, we have different types or varieties of periosteal reactions depending upon the kind of disease or the nature of the disease which is being affected. The first one is a lamellar type or an uninterrupted or continuous type. So there is no interruption. So basically it is a benign condition, not a malignant condition, and it is basically associated with inflammatory conditions like acute osteomyelitis. As you can see in this diagram, it is basically a raise of the periosteal bone, which is lamellar in pattern, different layers, which is uninterrupted and it is continuous. So this is most commonly seen in acute osteomyelitis. Then we have a typical onion skin or layered appearance wherein there's repeated deposition of periosteal bone, resorption of periosteal bone, again a deposition and again a resorption of the bone. So there is multiple layers of subsequent resorption and laying down of a bone, new bone. So it gives a characteristic onion skin or parallel layered appearance, which is again typical of Gary's osteomyelitis, Ewing's sarcoma, osteosarcoma, and chondrosarcoma. We can see over here there are multiple layers or which gives an appearance of an onion skin. Then we have a solid, thick, or compact or smooth kind of periosteal reaction, which is basically resolving Gary's osteomyelitis. What happens is basically in an active Gary's osteomyelitis, we have a multiple layers of deposition and resorption of the bone. But during the healing process, all these subsequent layers wherein resorption of bone takes place, since it is in the resolving state, this resorption stops and there is deposition of bone all over there also. So there's the parallel layers of resorption and laying down of bone. It is converted into a complete deposition of the bone. So there is a solid or a thick or compact appearance. So it is most commonly seen in resolving Gary's osteomyelitis, also seen in osteoblastoma or chondrogenic fibroma. We have something called as buttress formation, which is nothing but an deposition of excessive bone, abnormal bone, and raising of the periosteal bone over in that specific area with an invisible kind of cortical bone. The cortical bone is cortical margin as such is so thin that it is hardly visible on a radiograph. So it gives an almost invisible appearance of the cortical margins, but with a definite increase in the size or blown out proportions of the cortical margins. It is specifically again seen in ameloblastomas and ameloblastic fibromas. Then we have a lamellar interrupted or discontinuous kind. This is unlike the first variety where we have seen it is lamellar, but it is uninterrupted and continuous. This one is more interrupted and discontinuous, again giving a clue as to the nature of the disease. Is again seen in osteogenic sarcoma. As I said, it is more gives a clue about the nature of the disease. It is more aggressive, so it has to be something connected to a benign aggressive lesion or a malignant disease itself. So we can see in osteogenic sarcoma itself, which is a malignant disease. Now we have a solid irregular mass, predominantly seen in osteosarcoma. It is basically a solid mass of irregularly deposited bone, which has no specific shape. It is more irregular, again seen in a malignant disease like osteosarcoma. We have something called as Codman's triangle, which is seen in bony sarcomas. What happens over here is there is complete destruction of the bone at the center of the affected area, which is surrounded by a triangularly shaped bony deposition, which basically gives it is a characteristic or a typical appearance of bone sarcomas, where as you can see over here, the triangle bony depositions with complete absence of cortical margins in between them. Then we have sunburst or divergent kind of periosteal reactions, wherein hair-like irregular spicules of hair-like projections can be seen, predominantly again seen in malignant diseases like osteosarcomas and chondrosarcomas. Here you can see the elevation of the periosteal bone, the elevation of the cortical margin. We can see the irregular spicules of this deposition of the bone, which gives a characteristic sunburst or a divergent spicule appearance. Then we have irregular spicules, similar to sunburst kind, but it is not more regular, it is more irregular kind of spicular, irregular deposition of the bone on the surface of the periosteal elevations. Again, because of the benign nature of the disease, we can see it in osteosarcoma. Then we have something called as hair-on end appearance. This is also a spicular a kind of periosteal reaction wherein there is a deposition of the new bone over the periosteum in the form of a spicules. This is similar to a sunburst or divergent kind, but the spicules which we can see over here is much more smaller and more irregular in on the periosteal elevations. Is predominantly again seen in Ewing's sarcoma or odontogenic myxoma. So to come to a conclusion as to the radiographic analysis, the first and the foremost, as you can see in this chart, we have to estimate or come to a conclusion what is normal, what is abnormal, and even if it is normal, whether it is a variation of the normal, which is physiological rather than pathological. That differentiation depends upon the experience and the knowledge of the dental physician. And then we have to derive information from the abnormal structures. If at all it is abnormal, which is not a normal variant or normal structures, we have to know whether it is developmental in nature or since it has it been present since the birth itself, or is it acquired. Now within acquired we can classify it or derive a conclusion as to which kind of category of abnormal pathology it can be grouped under. Could be a cyst, could be a benign neoplasm, could be a malignant neoplasm, could be an inflammatory lesion or a bony dysplasia, or is it a vascular anomaly or a metastatic disease, or is it just a traumatic lesion. So depending upon what kind of group or what kind of radiographic appearance that abnormality shows us, we can easily with experience and knowledge classify it or group them under any kind of acquired anomaly or a developmental anomaly. Hence, coming to a definitive radiographic conclusion or a radiographic interpretation, which, if needed, in a combination with a second line of investigations, or if not needed, in combination with a provisional diagnosis, we can come to a final diagnosis as to what is the disease which is being disturbing the patient. So this brings us to a conclusion as to how we can interpret a particular radiograph. Thank you.